we're putting tens of millions of people in a very precarious situation where as soon as we hit a debt crisis, their access to healthcare could disappear.
But in terms of the reality of how people live and access care and et cetera, does that look a little bit different when you're speaking about someone who is under-resourced? Community health centers are often seen as a cornerstone of the primary care safety net, but they also raise some of the toughest questions in health policy today. They're locally governed, deeply embedded in the communities they serve, designed to care for patients who might otherwise fall through the cracks. At the same time, they rely heavily on federal funding, policy, and programs to operate. So what happens when you take that model and examine it through a different lens? One that's focused on incentives, limited government, and the role of markets in healthcare. Today, I'm joined by Michael Cannon, Director of Health Policy Studies at the Cato Institute, where he's one of Washington's most prominent voices on healthcare reform from a libertarian perspective. In this conversation, we'll explore what community health centers do well, where policy may be holding them back, and whether the current model is built for what comes next, or whether it needs to evolve. It's going to be a really great conversation. Excited to dig in. Michael, can you just introduce yourself and tell us a little bit about your background and what you do?
Sure. My name is Michael Cannon. I'm the Director of Health Policy Studies at the Cato Institute. I've held that position now for, I think, 22 years. And my background is in political science, law, economics. I've been doing health policy now for about 30 years. And was there more to the question? Did I touch all the bases?
I think you did.
Okay.
I mean, you've done a lot, though. Like you said, you've had a lot of years in health policy. I would love to hear about sort of your path to Cato, like, because I know you spent time in the Senate. You've done, so can you speak to that a little bit?
Like all young libertarian policy wonks, I couldn't imagine anything cooler than working at the Cato Institute and being able to work on a particular policy area and try to expand human freedom, people's ability to make the choices that guide their lives, and make a career out of that. In 1993, I showed up at the Cato Institute for an interview for an internship that I did not get. And I always like to remind our interns of that. So if you want a job in policy, you're already doing better than I was doing at your age. And but 11 years later, I got my current job. And in between, I worked for another libertarian organization, and then I worked on Capitol Hill, and then for another think tank that focused on health policy.
I think I know a bit about Cato, but for those who may not be super familiar, can you just speak a little bit to, like, what is the Cato Institute?
Sure.
What are they best known for? I'm assuming you're one of, many kind of working in this space, so would love to hear a little bit more about Cato.
So the Cato Institute is a libertarian think tank in Washington, D.C. It's been around since 1977, so we'll hit 50 years next year. And our basic approach to lifelong public policy is that we think that all humans are created equal, have equal worth and equal dignity, and that there's lots of kinds of inequality that get in the way of that, but the worst kind is when someone uses force or fraud to impose their will on you to get you to live their life the way that they want you to live it rather than the way you want. And so we think that you have a right to live your life however you want, as long as you respect the equal rights of others to do the same. Even if you think the way they do that is weird or even self-destructive, as long as it's not interfering with your rights to do that, we have to respect other people's rights to do that. And to protect all of those rights, we need a government. But we also need limits on the government so that it doesn't start to violate those rights. And when we look around the United States and around the world, we see governments violating people's rights in all sorts of ways all the time. And my career has been about trying to roll back the ways that the government violates people's rights when it comes to their health. Because, number one, it's wrong for the government to tell you have to buy health insurance, or you have to buy this kind of health insurance, or you can't buy that product until the government approves of it, or you can't hire this provider until the government says it's okay. It's wrong for the government to do that. And it would be one thing if when the government did that, we ended up with better, more abundant health care, but we don't. Every time the government gets in the way of you making your own health decisions, it ends up, instead of making healthcare more accessible, making it less accessible. And instead of improving the quality of healthcare, it reduces the quality of healthcare. And we would have much more abundant, much higher quality, and much more universal healthcare if the government just got out of the way and stop playing any sort of special role in that sector of the economy.
Got it. I've already like 7,000
1,000,
questions.
yeah.
But I love what you're saying, just in terms of, everyone should have and deserves equal rights, and, the things that get in the way of that we need to address, and,
It doesn't sound very controversial when you put it that way.
No, it doesn't.
But here in Washington, D.C., extremely controversial.
I mean, that's typical in Washington, isn't
Right.
it? So before, I want to really get into the health policy and the health reform, because I know you've done a lot in that space and over years. But before we dive in, I think you kind of just explained it, but just to sort of make sure, can you just, if you were going to really simplify a definition of libertarianism, would you just sort of restate what you said, or is there anything that you would add to it?
Is the idea that you have the right to live your life however you want, so long as you respect the equal rights of others to do the same.
Okay. So then another question for you, just to also kind of level set, how familiar are you with community health centers and with the health center program?
More than your average type bear, but not as much as other people in this room right now. I would say that.
Which is completely fine. But that part of my reason for asking is that, right off the bat, one of my questions for you is, I'm probably going to tell you things that you know. 60-year-old program. Came out of the war on poverty, which I'm probably a little controversial in terms of some of the things that you're talking about. But
well, if it actually fought poverty, it would be great.
Right.
But not so much.
Right. So, but that's its roots. It is the largest network of primary care providers in the country now, serving 34 million patients. It is the Section 330 of the Public Health Service Act. So you'll hear, the 330 grant. Basically, to become federally qualified, health centers have to be in a medically underserved area. They have to provide a comprehensive array of services. They have to have a consumer majority board, which is really unique to health centers, and something that, to be honest with you, kind of feels like maybe there are things that might appeal from that perspective. But the wisdom of it being, I think to your point, someone sitting behind a desk in Washington who might be well-intentioned isn't going to have an idea of what that community needs in rural Maine or inner city New York, whatever the case may be. It's going to be consumers and patients who are in a better position to say, okay, we have the framework that we have to meet in order to maintain that qualification, but if there's a lack of access to nutritious food, or there's stigma around mental and behavioral health, or there's a substance use disorder issue, it's then building services to respond to those needs of the community. So the Consumer Majority Board is that's the heart of the program, and I think part of why it's been so successful for 6 years, which we'll get into. But one of the questions I'll go right off the bat is that 90% of health center patients are at or below 200% poverty. So you're talking about folks who probably would not otherwise have a place to access care outside the emergency room, or go without entirely. But I would be curious, so fundamentally where you started here in terms of everyone having equal rights and sort of the interruptions to that, but from your perspective, does that look a little different? I mean, fundamentally it won't, but in terms of the reality of how people live and access care and et cetera, does that look a little bit different when you're speaking about someone who is under-resourced?
Well, the reality of how people live and access healthcare is much worse because of all the ways that the federal government and state governments take away our right to make all those decisions for ourselves, and the right of others to try to offer us something better than what we've got right now. And so a bunch of thoughts came to mind when you're talking about community health centers. And one of them is that when advocates of CHCs want to talk about how they're community oriented, they'll call them community health centers. Mm-hmm. But they'll drop off the federally qualified part. Mm-hmm. When they want to talk about that. When they want to talk about, standards, we'll say, federally qualified, but community. And they have the boards with, you have, people from the communities that the health centers serve that serve on the boards. And so that is a modicum of local control. Mm-hmm. But the money is coming from the federal government. Mm-hmm. The rules are coming from the federal government. The federal government is overriding state laws when it comes at least to things like medical malpractice liability. If someone gets hurt by negligent care in a community health center, all of a sudden what the locality thinks, what the people on the ground there think, doesn't matter anymore because those rules the federal government supplants those rules, and you have to use a federal law to resolve those disputes. And so there are a lot of there's a lot of very prescriptive rules that come from the federal government that govern how these centers work. They're also not as local as they could be vis-a-vis state regulation, because, or I should say more broadly, the way that people access care is not as local as it could be. So in every state, you have to get permission from the state government if you want to practice medicine, if you want to go into the nursing profession. Also, if you want to create a new clinician category, that a new profession that might be able to provide medical care more affordably. And so, what this ends up doing is taking away your right to choose, maybe to see a nurse practitioner independently, maybe going to see a dental therapist rather than a dentist for your dental care. And those regulations that block your ability to make that choice for yourself end up driving up the cost of primary care and dental care, and making things like federal subsidies for community health centers seem more necessary. So these are just a couple of the ways that we've taken control over our healthcare decisions away from entrepreneurs and from the consumers, and driven up prices and made it seem like we need subsidies for organizations like federally qualified community health centers.
2 questions. There's a lot. But so one would be, is there anything within the health center model that you would pull out to say you like this, or it aligns with sort of what you have in mind? And maybe the other question that we start with is, if you had the magic wand and you could perform healthcare, and this is, I know that this is like decades of work for you, but in as much as we can have the conversation here, what does health reform look like? And then is there a role, is there a space for health centers in that?
So if we're talking about government-created clinics, where that are getting government subsidies, where the politicians here in Washington, D.C. get to decide how much, and the lobbyists for the health centers and for others wrangle over how much and what the rules are, I don't think that process serves patients very well at all, and I don't think we need to be doing that. That doesn't need to be any part of what we're doing. The resources should follow the needs of the community rather than the political power of the various interest groups in Washington, D.C. And if what you wanted to do was have community health centers that are more responsive to patients, then I think the way to do that would be something akin to what I've proposed when it comes to reforming the Medicare program, which is, instead of all of these very prescriptive rules that the federal government writes about how seniors can access health care with these subsidies, turn Medicare into something more like a Social Security type cash transfer program, where you just give the seniors the cash. And this is Medicare we're talking about, so this would be a lot of cash. Right. Medicare spends a lot of money. And then they would decide where that money goes, what kind of health plan they buy, what kind of hospital they go to, or non-hospital facility, and that's actually key. And they'll be much more price sensitive than they are when they're spending the government's money, and that will drive prices down. What does this have to do with community health centers? Well, right now, because we have so much of our healthcare spending in the United States that the federal government controls and decides how people are going to spend it, the federal government is not very good. Government in general, and our federal government in particular, is not very good at deciding where the money should go. The Medicare program sends tons and tons of money to hospitals, obscene amounts of money to hospitals, and to pharmaceutical companies also. But let's talk about hospitals for the moment. And Medicare enrollees don't have much power or incentive to do anything about it because they don't see any of the savings. If you took that $1 trillion that the federal government is spending on Medicare, gave it to seniors on of course, a risk-adjusted basis. So if you have a higher disease burden, you get more money. People would be able to afford all the medical care that they're getting right now and more, because they would move away from the high-price hospitals to the lower-cost facilities, including clinics, community health centers, because they would get to reap the savings. And we would be able to reallocate a lot of our healthcare spending away from inefficient dinosaur hospitals toward more efficient, ambulatory surgical centers and other lower acuity facilities. There'd be more of a focus on primary care as a result, and so the facilities and the people who work in those community health centers might actually get a larger piece of the pie, but I wouldn't want, I would want to eliminate the federal government's control over how they operate as well, so that they could be more flexible and meet the changing needs of Medicare enrollees, and I could talk about similar reforms for other patient populations. And I think we would get much more responsive, higher quality, and lower cost care than with the current Medicare and CHC model that we've got right now. And I haven't even talked about state level reforms to help some of the innovators and entrepreneurs within community health centers who can't innovate right now because of regulation.
Yeah. So there's lots of things within the system as it exists now, and I realize a lot of what you're speaking to is again, if you had the magic wand to kind of dismantle as it exists. But for the sake of just sort of, okay, what do we know about health centers right now as they exist in the system? It's a $13 savings for every dollar invested in the health center. And that part of that has to do with accountability. There's tons of transparency and accountability with health centers because of the federal requirements. So I see that cuts both ways, but it does at least provide the proof positive of improved health outcomes, savings on that investment. Some of that is primary care, but also I think to your point around they are exceptionally responsive to the needs of their community, even within the guise of sort of what they're required to do. And I get it, we can debate over the requirements that the government is placing on them, but we would like more flexibility too, I will say, in terms of adjustment to scope and care teams and what does it look like in terms of whole person care, all of the things I think you're getting at. There's a decent amount of flexibility working with HRSA, the agency that oversees the program, and the Bureau of Primary Health Care. But there's more that we can do, and I think, as to your point, the needs of humans are continuing to evolve. The role of technology continues to, drive us in a different direction. But as it exists right now, I will say there is a lot of innovation happening at health centers by necessity, because they see what's going on in the community and they're pretty quick and agile about, okay, we have to do this. And sometimes they're doing it they're not getting government funding for it. They're getting creative, and whether that's, finding outside grants or setting up a new service line that can feed mission. So there is some of that happening. And I think that's part of why I wanted to talk with you, is just to find sort of okay, there are some who might say we're just on totally opposite ends of the extremes of perspectives and ideologies, and that maybe yes, maybe no. But I think there are spaces in the health center world that do lend to some of the vision and the model that I'm hearing you talk about. I think one of the questions, though, around patient choice, for example, or your conversation about putting resources, using Medicare as the example, sort of putting the resources back into the hands of seniors. There's two pieces there that I'd love to hear you sort of get into. One, healthcare operates a little differently, right? Because in most cases, if you have the resources, you're not bargain shopping. You're looking for the best results, who is actually producing, the best outcomes, which then also, at least in the system we operate in right now, usually is the highest price point. So, yeah, I mean, no, please disagree. Tell me where I'm wrong on that, because that's my anecdotal observation of just sort of watching in a public health setting. But I think across healthcare in general, the last 20 years, they're just sort of well, if somebody has the option, oncology, for example, if somebody has the option of shopping for who their oncologist is going to be, they're probably not going to go with, well, this guy, the package is X and this is the price point I can afford, versus this guy is the absolute best specialist. If they can afford the specialist, they're going to go there.
Well, I made a face in response to the claim that higher price means higher quality.
Right.
And a lot of people assume that, but the quality metrics and data that we have in healthcare are so horrible.
Yeah.
But people just fall back on that presumption because they don't have anything else to go with. And I'm not sure that is the case, that just because they're charging a higher price means they're higher quality.
Correct.
In fact, sometimes it can mean the opposite.
I would agree with you there. I think our, access to data, especially real time and, over the course of time, I totally agree with you. It doesn't always, price does not always equate to quality, although it does in some cases. But I think I bring it up just because healthcare is different in terms of from a market perspective. It's not exactly apples to apples, at least from my perspective,
Right.
in terms of like, I'm going to bargain hunt for my, it's sometimes you don't want to take that risk. And sometimes the highest price point is truly somebody who is the top expert, who has the best outcomes. Maybe they're even the most innovative. It could be a number of different indicators. But so I think like sometimes I have a hard time wrapping my head around how that works in terms of sort of the model you're talking about in terms of the example you provided with Medicare. But then the other question I have for you, or I'd love sort of your thoughts on it, is when you're talking about our population, the health center population, many of them are really challenged with a variety of just complexities in their life. And whether that's, English as a second language, it could be, multiple jobs and multiple kids and just doing the best you can to keep it all together, or, a lack of education, or, a lack of jobs. It could be transportation. It could be just, there's so many different things, right? But so that's the other question I have for you is sort of like, okay, so if you're talking about a population, some percentage of which hasn't had, for example, education around financial management, or where English is a second language and so there's a translation barrier, like what happens with that in a model in which you're sort of empowering them, but they don't have the tools, or they haven't necessarily had the access to training and education to leverage that sort of empowerment in a way that is going to bring them the greatest benefit?
I think we'd have even more tools at our disposal to help folks like that. And here's why. So I mentioned before nurse practitioners, dental therapists, and so forth. There are a lot of regulations at the state level that make it harder for people to make health care more affordable for the poor. These have to do with primarily clinician licensing laws that make healthcare more expensive in some complicated ways, like the profession of a dental therapist is one that most people haven't even heard of, but it's somewhere between. It's like a nurse practitioner for dentistry. It's somewhere between a hygienist and a dentist. Mm-hmm. Can do some of the things a dentist can, not all of them, but a lot more than a hygienist can. And if you're talking about a simple extraction or filling a cavity, much more affordable than a dentist. But if you want to create that new clinician category with less training than a dentist, so the student debt load isn't as high and they can charge lower prices, you need to get the permission from the government. And before you can do that, guess who shows up on that day to tell the legislature, no, you shouldn't create this new category. It's the dentists, because you'll be competing with the dentists. Right. That happens over and over. And again, in dentistry, in medicine, the physicians say, no, the nurse practitioner shouldn't be able to practice independently. They shouldn't be able to prescribe. You shouldn't be able to create this other new clinician category over here who's going to compete with us. As a result, we don't get the benefit of the natural market processes of specialization in the division of labor that would be driving down the prices of all of these goods and services to the point where more and more people could afford them, and fewer people would need to go to community health centers. Also, the community health centers would be able to benefit from that innovation as well. So I guarantee you in every community health center around this country, there are innovators. There are people who are looking around saying, you know what, this is dumb the way we're doing this, or she could perform that service even though her license says she can't, and I could just train her in a few weeks, and then we'd be able to help so many more patients. But regulation says no, they can't do that. In community health centers, you would have first of all, the burden on them, if we eliminated these regulations, the burden on them would be much lighter, because more and more people would be able to afford medical care without subsidies, and dental care without subsidies. But also the people who are then engaged in providing subsidized care to people would be able to do it much more flexibly at a much lower cost and be able to help more and more people. And here I'm telling mostly a regulation story about how we would need to remove those government barriers to lower price care. And I think if we do that, we would see we don't need nearly the government subsidies that we think we need to provide the level of care, or even a higher level of care than we are right now.
So it's interesting. So some more context when it comes to health centers. So national average for health centers, they're operating on a 1% to 2% margin, if that. A lot of them are in the red. Their 330 grant, which is when they become fairly qualified, those are their dollars that are intended to support sliding fee for under and uninsured. So it's not very much. It ranges from health center to health center, and the saying in the space is sort of, you've seen one health center, you've seen one health center. But the percentage of the sort of revenue pie for that 330 grant could range anywhere from low single digits up to, maybe 20, 25%. But it's not the majority of their overall pie, if you will. And then, and I'm going to tell you lots of things, then bring us back around, because there's some workforce stuff that I'd love to chat with you about. But so Medicaid is a really important program for health centers, both because of the coverage it provides for patients, and I know we're going to probably disagree in terms of Medicaid, that's okay. But it's also a really important program because, you may or may not know, health centers receive a prospective payment system for caring for Medicaid beneficiaries. What that looks like is, it's a cost-based reimbursement, but health centers have to provide a wider array of services. So basically, in order to have that reimbursement rate, it's not just, oh, okay, come in, you have a sniffle, and I've checked you, and go on your way. It's enabling services, it's transportation, it's vaccination. It's literally, we're going to take care of everything when you come in, one-stop shop, sort of under one roof. So that reimbursement rate is to cover sort of all of those services. Usually it's actually under what it costs them. So they're operating at a loss with that.
Per person or per episode of care, or?
Per episode of care, so per visit. There are restrictions on that, with good reason. But the importance of it, because it's usually less than what their actual cost is, but the importance of it from an operational perspective is that it allows them predictability. So even if they're taking a loss, let's say their total cost for seeing a Medicaid beneficiary or Medicaid patient is $213, but their reimbursement is $167. At least they can guarantee, okay, we're going to get $167. We'll figure out how to make up the rest. And that's what they do. Honestly, health centers are incredible and masterful at figuring it out and stretching the dollar and getting creative. But the Medicaid program is really important, and something that we're actually facing and dealing with right now is with the changes with HR 1 and the anticipated number of people who will fall out of coverage, reality of why and how, it's just, that's what's going to happen. Health centers are required to see everyone who comes through their doors, regardless of ability to pay or insurance status. So basically what happens is those patients come in now as uninsured, but they don't have any additional dollars coming in to cover that.
Because there's no more Medicaid,
there's
$167.
Right, there's no more $167, and the $330, their grant dollars, which is intended to cover the cost of that uninsured, that hasn't changed since 2018.
Right.
So they're now in a situation where they are literally bound by law to see everyone who comes in, and they want to provide care for continuity for their patients, but from a financial solvency, they can't do anything. They're not a private provider.
Nothing.
Well, but here's the thing, they can't adjust their rates because of restrictions. So it's not like a private provider where they can say, okay, the market has changed.
Okay, whose restrictions?
Government restrictions.
The federal government's restrictions,
yes.
Right. Okay.
So, this is where, again, there are certain things where I agree with you. Like, there are major challenges and the realities that health centers face because of that. It's a problem.
But you mentioned another margin where they can try to make up the gap, which is grants. So, and so they can go try to get funding from other levels of government or non-government.
I was going to say it tends,
donors.
Right. There's some state support, depends on the state, but I would say it's less other government funds. It's more in the space of private foundations, community oriented.
Are there federal restrictions on what kind of money and how much you can take from those organizations?
I'd actually have to look into it more deeply. I mean, outside of, they're all 501c3s. Right. So from the perspective of can they take dollars that are going to be in conflict with that? No. But I really would have to dig into like what they could or couldn't do. There's nothing off the top of my head that's like, well, they can't take those dollars. Yeah. They might have some ethical sort of like, well, we don't.
It's a question that just occurred to me because I could imagine some reason why but maybe they're not.
Yeah.
But so that's a real problem that those organizations are going to have to face if a lot of people lose their coverage as a result of HR 1, the One Big Beautiful Bill Act. And that's certainly plausible to me, but and it does concern me, but I think the news is actually much worse than that.
Mm-hmm.
The reason being the whole episode with the One Big Beautiful Bill Act and the fiscal picture facing Medicaid and community health centers is actually much worse than that law portends. And the debate over that law shows that that Medicaid enrollees are in a much more precarious situation than anyone realizes. Let me unpack what I mean by those two things. First, the federal government is, it now has a $30 trillion debt. That's the size of the entire U.S. economy. We're at 100% debt to GDP ratio.
Yeah.
This is new territory during quote unquote peacetime.
Yeah.
And it's one of those examples of Stein's law, which is if something cannot go on forever, it will stop. Congress can't keep borrowing money forever.
Right.
And when it stops, when Congress hits some sort of constraint, and that could be Congress gets religion, balanced budget amendment, debt crisis,
right.
when something happens that where Congress can't keep spending money at the rate it's spending, it's going to have to start cutting, and it's going to have to start cutting healthcare.
Yeah.
It's going to have to cut healthcare because that's the largest category of federal spending, and the only one that it's growing as rapidly as it is, outpacing GDP the way it is. And when Congress goes to cut healthcare, it's going to cut Medicaid first, for the same reason that it went after Medicaid in the H.R. One Big Beautiful Bill Act, because to put it very crudely, poor people don't vote in the same numbers seniors do.
Yeah.
And because it's a joint federal state program, so they can say, the states can take care of it.
Right.
We'll dial back the federal contribution and states can pick up the slack.
Right.
So that's coming in a way that makes H.R. 1 look like child's play. In fact, I'm not even sure that Medicaid spending has gone down overall as a result of H.R. 1, and I think it may not. But what the debate has shown us is that this spending, the level of spending that we're seeing on Medicaid right now is not popular, and everyone knows it. That voters don't want it. And I say that because what were the estimates that we heard? Like 10 million people will lose their coverage.
Yeah,
12.5 million people will lose their coverage as a result of the work requirements and provider tax restrictions and other elements of H.R. 1. And yet, and everyone took that as gospel. So federal government pares back or puts the brakes on Medicaid spending, and everyone assumes that means people lose their coverage. But there's a very important intermediate step there, which is states. States could replace every penny of that money.
Right.
If their voters are willing to pay the higher taxes or go without the other services necessary in order to do that. But everyone assumes that voters are not.
Correct.
What does that tell us? That tells us that spending, or Medicaid spending at current levels, is higher than voters are willing to support by cutting spending elsewhere or through higher taxes. That means that Medicaid spending at current levels is unpopular with voters, and and it's not just the people who are showing up at the community health centers as a result of H.R. 1 who are in dire straits. We're putting tens of millions of people in a very precarious situation where as soon as we hit a debt crisis, their access to health care could disappear. Yeah. And so that is why I press so hard on these reforms that would make healthcare more affordable, particularly primary care for low-income people, and that don't cost taxpayers a dime. They are removing these regulatory barriers to lower-cost care because we should be implementing them now. We at the Cato Institute a week or so ago released our handbook on affordability. It's the latest buzzword. Everyone likes talking about affordability. And I think every single healthcare recommendation we put in there is one that would make medical goods and services more affordable without costing taxpayers any money. And we need to be doing those things now because it's the right thing to do. But also when some sort of fiscal crisis hits, and even more Medicaid enrollees and maybe Medicare enrollees lose their subsidies, can't afford the level of access they could before, we need to hit the ground running when that happens. We need to have more affordable models in place before that happens.
So I agree with that. I think my question for you, though, is, and I get that sort of in the current model or system, because of the way health centers are positioned, it doesn't totally align, I think, with what you have in mind. But it is the largest network of primary care in the country. And I think where we agree is that, greater investment and attention in primary care instead of when someone is, further down the way in whatever issue or ailment they have is the right way to do it. So here's a great example to sort of connect the dots on this. My question really is like, okay, but there has to be dollars that flow into health centers, whether it's coming from the feds or otherwise, whether it's, tax dollars or somewhere else. Like without that investment, even if people are going to lean into primary care, where are they going to go? Health centers are already there, so it makes sense. Why would we not, lean into that? But so a great sort of connection here, and I'd be curious to hear what you say. Are you familiar with the 340B program?
Mm-hmm.
Yeah. So the 340B program is interesting, right? There's a lot of things about the program that are interesting, but just in the context of why and how it is interesting for health centers. Some context for you. So health centers were really kind of, at least in terms of 1992 when they created the 340B program, health centers were exactly who they created the program for in order to stretch scarce resources, because as you know,
Sure.
they're not federal dollars. It's completely separate. And
Go on.
okay, thank you. Give me liberty on this one. So health centers have verified, honestly, through congressional hearings and you name it, over the course of years, that they are using the dollars in the program as it was intended for patient care and access, and it's all going back into the community, into patients. It is an extremely important source of revenue for health centers, especially as things like Medicaid dollars continue to change and reduce, because those dollars allow them to expand access to care. And, in the current environment, things like maternal care, where if they didn't have 340B dollars, there would be zero access to maternal health care in certain communities across the country. So, but it's an interesting program, right? Because it's not attached to tax dollars. So, for the most part, it's not, our taxes are not supporting, those are not the dollars that are coming back through the 340B program. And for that reason, I'll call out, there is no congressional incentive for them to do anything to reform the program, because if they do, they're going to tick off two of the largest interests at stake, right? Pharma or hospitals. Health centers are caught in the middle of that.
Right.
We're
yeah.
5% of the 340B spend. But we have a hugely outsized impact in terms of the continued erosion of the program. But I'm curious to hear sort of like, okay, so this is an example, and obviously we have a debate here of whether or not it's actually, connected to tax dollars. But for the sake of the conversation, let's say it's largely not. So like what?
Not directly.
Okay, well, please tell me what you think.
So the 340B is such an interesting microcosm of the dysfunction that government brings to healthcare. So and it came about because of this. The short version is government overpays for drugs, and hospitals are capitalizing on that, and pharma hates it. And so they're trying to get the money back. Mm-hmm. They want to overcharge the government, not hospitals. Okay. So the way this came about was Congress creates the Medicaid program in 1965, and around the 1980s, they realized, wait a second, we are paying way too much for drugs. These drug companies, because of cost plus reimbursement, which dominated the Medicare and Medicaid programs for a long time, where you say to people, where the government doesn't have a market price mechanism to determine what the prices will be. So they kind of come up with some pricing rule or mechanism. So they ask people, how much did it cost for you to make this pill or provide that annual checkup? And the drug companies or the doctors will say, you're asking me? And then they'd come up with some number that kept rising year after year. And there's no incentives for economy, just incentives for them to jack up the prices. The government starts overpaying. And in the 1980s, they realized, we're overpaying for these drugs. So they said to the drug companies, in 1990, we want you to give us, the government, your best price. And the drug companies said, okay. And they jacked up the prices on everybody.
Right.
And then gave the government the lowest of those higher prices.
Right.
And so that didn't work. And the hospitals said, ouch. these higher prices are killing us. Give us the 340B program. So 2 years later, Congress creates the 340B program that says to the drug companies, if you're participating in the Medicaid program and getting these still outrageous prices that we're paying to you in the Medicaid program, then you have to give lower prices to these hospitals.
I don't think it was necessarily just hospitals.
Well, hospitals and others.
Right.
So the drug companies say, fine, we'll still be making a killing off of the taxpayers. Right. And they lower the prices for the hospitals. Well, the hospitals are the drug companies aren't dumb. The hospitals aren't dumb. The hospitals get these lower prices than everybody else, and they say, wait a second, we can pay these lower prices and still bill the insurance companies, right, and maybe even sell the drugs ourselves at a markup. And so now the hospitals. So the government's overpaying everybody, and the hospitals are now taking an ever-increasing slice of pharma's pie of those excessive prices. More and more hospitals and community health centers are qualifying for the 340B program, and they're able to get in on this racket. And pharma hates it. They want those overpayments. They don't want them going to the hospitals. Right. And so when you say that there's no taxpayer money involved, and I say it's because the reason we don't have competitive pricing for pharmaceuticals, one of the reasons, is that the Medicaid program creates this system that the pharmaceutical companies can game to jack up their prices. And if that system weren't in place and the pharmaceutical companies weren't able to make so much money off of Medicaid, then they wouldn't participate in 340B anymore. They'd say, forget it, hospitals, your sweetheart deals are over, and we're going to be charging you the same prices as we charge everyone else. If it weren't for the subsidies pharma is getting, then the hospitals and the community health centers would not be getting these lower prices than everyone else, but they might be getting prices that are even lower than that. We don't know, because we don't know where the market would shake out. But there are a number of lessons here. One is that government is just terrible at this, and what we think of as private sector greed is just government incompetence and people fighting over the spoils of that government incompetence. And I don't know why we should think that anything that pharma wants or anything that the hospitals want out of this is going to serve consumers or community health centers. Now, does the 5% of these ill-gotten gains that goes to community health centers keep me up at night? No. Because compared to the hospitals, you're probably not buying artwork.
No.
With the 340B money.
100% going back into the patients in the community.
And when I don't think the government should be taxing me to support anyone else's health care, partly because I think fewer people would need assistance and we'd have better health care. But when the government does that to give money to community health centers to help low-income people get basic primary care and other things, that bothers me less than the artwork in the hospital lobbies. But still, when I see the 340B debate in Washington, D.C., I just laugh because the fact that that's even on the agenda, that's like a big issue for Congress, just shows how captured the entire process is by special interests and how consumers have absolutely no voice. And it reinforces my conclusion that government should be playing no role here.
So I think it's interesting. So I understand what you're saying in terms of it's circular, in terms of the dollars and taxes, and I do understand what you're saying as it relates to that. Although I will still continue to say it's not tax dollars. The program itself, the dollars are coming from pharma.
But if it weren't for the tax dollars going to pharma, community health centers wouldn't be getting these great prices on the 340B
Yes, that's the circular part that I can see for sure. But I do, I think where we're on the same page is no, health centers are not, there is, like I said, it's 1% to 2% margins. It's not putting fountains up in lobbies. It's not artwork on the walls. It's literally recruiting and retaining staff.
Football players or anything like that. It's
literally maternal health care. It's mobile units to be able to get to patients that otherwise wouldn't have access to care. So it is really hard. And health centers are very much caught in the middle of what's going on.
Very low cost, high return interventions like hypertension control and prenatal care and reproductive care.
I mean, so again, we're sort of just thinking about the bigger sort of financial reality for health centers, whether we agree or not in terms of the, systems around it. The reality is between, grant dollars that haven't changed since 2018, and even just thinking about
federal grant dollars.
Yeah.
Right.
So the $330, that hasn't changed for health centers since, in terms of like what their grant looks like, that has not changed since 2018. So in that time,
In fairness, since 2014, though, there's been a flood of money from Medicaid.
Through Affordable Care Act and expansion.
And the exchanges, more subsidized patients there, and so it makes sense to freeze those grants maybe in 2018.
Yes and no. So here's what I'll say is that the number of patients has also gone up. And so it's not exactly proportional. So I do understand what you're saying, but health centers continue to see more patients. The need is still actually even more and more. And so they're continuing to pick that up, but they're not. And then the other thing, like we were saying before, or what I mentioned, is that it's not like a private practice where they can just change their rates. The cost of goods has gone up. We're going to adjust $20. It doesn't work that way. And so health centers are also operating on, whatever their reimbursement structure is, that's where it stands. And some of that is state regulated, and every state's different. So that's a whole mess. And we haven't even talked about value-based care, but that's the reality. So you have, difficulties in terms of grants that have not budged, despite inflation and costs, the increased costs, et cetera. You have now massive reductions on the Medicaid side, and you have an eroding 340B program. And then, so this is the other thing I wanted to chat with you about, is the workforce component. So, as you are well aware, there's a huge workforce shortage in the healthcare space. Recruiting and retaining providers, but frankly, like healthcare workforce as a whole, it's no longer just MDs, DOs. It's every layer of healthcare. Yeah. It used to be that health centers could really push on mission, and just some people really want to work in that kind of a population with the complexity of demands and lots of different pieces, and they could be competitive in terms of what they were offering for benefits, programs like the National Health Service Corps for loan repayment and scholarships, that kind of thing. But through the pandemic, that's changed enormously. And so where we already had a health professional shortage, now there's, increased competition across the space. And so health centers are at a huge disadvantage because they don't have, extra resources to be able to find ways to be competitive in an additive way. But they have become, this is a great example of innovation. Many of them, by necessity, have created homegrown health professional education and training because they have to. So they have MA programs.
I told you they were innovative.
Yeah, they are. And that's like scratching the surface. So they've done these incredible things to create training and education programs, because the other thing we know from data is that people tend to stay where they train. So if they train and they learn in the health center, then they're very likely to stay in that community or go to another community that's similar. So there's incredible programming, education, training happening at health centers all over the country. Now, a lot of it has not been supported by government funding. They've done this creatively on their own.
And what sorts of training? What sorts of roles?
So everything from medical assistants, dental assistants, nursing, you name it. And then there's the teaching health center GME
nursing,
program.
You just mentioned a licensed profession.
Yes.
Okay. So
but there's community health workers, there's doulas, frankly, a lot of
So far it sounds like a lot of the innovation is coming from in the unlicensed professions.
No, a lot of them are licensed.
So are the community health centers like starting their own nursing programs and then graduating people so that they can get a nursing
Yes, but
degree?
There are challenges with that. And that was actually one of the questions. So on the one hand, I'm really proud of the innovation and the incredible contribution, frankly, that they're making to the healthcare system as a whole and primary care in terms of doing the training and education for the next generation of providers of all different skill levels. And it goes beyond that. I think health centers have also, many of them, one of our members in Kentucky, for example, has this program called the RAISE program, where literally anyone inside the four walls of the health center has access to these pathway programs. It could be in clinical, it could be in operational, IT, you name it. But you're talking about a rural part of Kentucky where they had massive issues with not just retention, but with vacancies. And now they have a wait list to come work at the health center because they've created a scenario where somebody can learn and have
a wait list to work at the health center.
Yeah.
Fantastic.
So, but it has not been easy. It's required getting really creative in terms of how they bring dollars in, because this is not something that the government is funding. There is the Teaching Health Center GME program. So, and that is, there is federal funding to support that, but it's limited, but part of the reason I bring this up is that the whole country is facing a healthcare professional shortage, and I think the interesting thing is we're moving in a direction where you don't have to be in an underserved community or happen to be an under-resourced person, and you're going to have a hard time finding access to a primary care provider before long. Partly, in your case, I will agree with you that some of it has to do with licensing and sort of like how are we determining who's qualified to provide that care, but it's no longer going to be an issue for medically underserved or health professional shortage areas. The entire nation is going to be facing this. So I look at the health center program and all of the incredible innovation and education and training that's going on, including the Teaching Health Center program. And I guess my question is why and how? Why are we not putting more investment there? And if it's not coming from the feds, what is your suggestion for how we do that?
So I don't like talking about clinician shortages for a number of reasons, mostly because I don't think we should confuse the producer with the product. Nobody needs a doctor, really. Someone might need high quality, competent medical services, but maybe some of those could come from someone with less training than a doctor who doesn't cost as much. Doctors like to talk about physician shortages, and we have to deal with a physician shortage because they want to reinforce the idea that the health sector should revolve around physicians, and they don't want to talk about trying to meet the unmet need by training nurse practitioners or physician assistants to do the same tasks, because that means lower incomes for physicians. I definitely think there is an alarming scarcity of medical services. And so I was talking to a reporter one time recently about long-term care. And she asked, what's the number one thing that we could do to expand access to long-term care, make it more affordable? I said, open borders, eliminate all restrictions on peaceful immigration, because the world is full of competent people who'd love to come to the United States and care for grandma and grandpa and do it in a compassionate way. But we drive up the price of long-term care by keeping them out. We also drive up the prices for medical goods and services by keeping competent clinicians who have their training in other countries from coming here and meeting the need. And so at the Cato Institute, we've done a lot of work on eliminating unwise immigration restrictions. We've done a lot of work on eliminating specifically restrictions on foreign trained doctors and eliminating accreditation rules that say you have to have trained at a U.S. or Canadian medical school or a U.S. or Canadian residency program in order to practice in the United States. There's this whole web of regulations that are contributing to the shortage of medical goods and services, and strategies I think that mostly at the state level that we need to adopt. And I think if to deregulate, and I think if we did, we would see a lot more of the sort of innovation and experimentation that you're talking about, where you're running a community health center, or it could be an entire health system, and you think, you know what, the people who are training clinicians are not giving us what we need, or the market is not offering it to us. We can't buy it. We got to build it. Let's put together a training program. We've been at the Cato Institute writing about those sorts of innovations when it comes to sexual assault nurse examiners, sexual assault forensic exams. That happened because RNs in emergency rooms said, wait a second, there are better ways of doing this. Let's create our own training programs and credentialing and so forth. And similar things happen. That's how we got the profession of dental hygienists and so many others. But we're not seeing the benefit of those, of all of that entrepreneurial energy from people who are out there and know how to solve these problems and make healthcare more affordable. Make that community health center dollar go even farther than it's going right now.
So it's interesting because I often refer to our members. So ACH's members are some of the largest health centers in the country. So They are, in a lot of cases, health systems. But one thing that I see, certainly across our members, but also I would say for many, many health centers across the network, is that they're social entrepreneurs. So they are thinking outside the box, and especially in this environment, they have to. Right now, in order to stay solvent and to withstand a lot of what's happening and the transformation that's happening in the system, they have to do that. But I think, I agree with you in terms of it isn't just physicians. This is all corners of the healthcare workforce. Like I said, teaching health under GME, it's an incredible program, but there are limitations. And so it reminds me a little bit, something that I've been saying for a while is that in some ways I feel like we're in the midst of a Phoenix story where a lot of things are getting burned down, but I'm hopeful and excited that what can come out of it is something really beautiful.
I want to know where you see the things burning. I don't see anything burning yet.
I mean, it feels like in the health center world, everywhere you look, there's fires right now.
Okay.
Truly.
Well, I think those Phoenix moments happen all the time, actually. I get myself in trouble sometimes when I speak in favor of rural hospitals closing because they're often, the largest employer in a community. But if you want healthcare to be as universal as possible, you have to let the old inefficient institutions, providers go out of business. And so you can free up those resources and something can rise from the ashes, as it were, to stick with the metaphor. And in rural hospitals, before they close, what ends up happening is the people in those communities say, we don't want to go to those hospitals, we're going to go to this farther away one, and that's why those rural hospitals close. That happens all the time. I was hoping you were seeing something on a larger scale, but unfortunately, the subsidies and other things that allow the dinosaurs to limp along a lot longer than they should be able to are still all in place. And so I'm not seeing any sort of transformative.
But what happens, and I hope you won't find this argumentative, but like what happens, so like that example, and I mean, I get what I think I understand what you're saying in terms of like being okay with rural hospitals closing. I think it depends on the situation. And I would always advocate for it needs to improve. We all have to do better. But I think my question is, and again, I think of our health center patients. So what does it look like? So, and you said, some people will just drive further, but what if they can't? What if they don't have the resources? They can't afford the gas money. They don't have a vehicle. Right. So to me, that then takes me to the space of like, all right, then they just literally don't have access to care. So if they have a chronic disease, or they have, some kind of medical episode, they really are at risk for death. And that doesn't feel acceptable to me.
Right.
So what happens then?
So when the issue is rural hospitals and access to high acuity care in remote areas, there are trade-offs and there's no way around them. The answer, I don't think, is we should just have the government subsidize a rural hospital on every rural street corner. Or if someone decides they want to live out in the woods somewhere, we should build a hospital nearby them so that they don't have to drive very far to get to one. And that sounds far-fetched, but I think that what we do with hospital funding in this country is closer to that than you might think. And we started out by saying that the Medicare program throws a lot of money at and props up a lot of hospitals that probably shouldn't be there. They're larger than they should be. They're charging higher prices than they should. And one of the reasons we have the most expensive health sector in the world is because the Medicare program does so much to create so many hospitals that are too big and charge too much. And if instead we had a system, and this could be a health system that involves subsidies, but one where the consumers control all $5 trillion, the hospitals would find them, but more importantly, the lower cost providers would find them. Mm-hmm. And you would have people experimenting with what is the best way to get within the reach of these folks in remote areas, the sort of medical care that they're most likely to need, and at the lowest cost possible.
So can I ask you something?
That's not the approach that we take right now, and I think we have the excessive prices and waste to show for it.
This is really, I love that we're having this conversation, because my question is, like, when I hear you describe that, so is there a scenario in which health centers could be the foundation of that?
When you say health centers, you probably mean federally qualified community health centers. When I hear health centers, what I think is that could be anything. And sure. And what I do love about federally qualified community health centers is not every part of them is federally qualified. Some of it is private funding, and that's and outside of the government subsidized and regulated parts is where you get most of the entrepreneurial energy. And that's the sort of community health centers that I would love to see experimenting with different approaches to getting people the care that they need. And we're, to the extent that the money that they're getting has federal rules tied to it, or to the extent that their ability to, you have state clinician licensing regulation that's restricting their ability to innovate, I think what they're going to be able to meet fewer needs. What they're going to be able to do is going to be less impressive. So I love the idea of having these sort of centers out there that are charging the people who can't afford something what they can afford, and using whatever else, whatever resources they have to provide to the people who can't. So in that sense, yeah, definitely could be a part of this.
Okay.
I just don't think that the federal subsidies or the government subsidies or regulation has to be a part of it.
So we got to work on that.
And I should say, for the sake of accountability, they should also have to be subject to the local medical malpractice rules, because when you have providers going to the legislatures to say, why don't you impose on judges and juries this set of malpractice liability rules that make sense to us, it ends up just being provider protection, like licensing is provider protection. And we've done work on that at the Cato Institute as well. And I can already hear the providers complaining about what I just said. They'll say, oh, well, we'll get runaway verdicts against community health centers, and we won't be able to stay in business if we have jackpot justice that sends our liability insurance premiums through the roof. Much better to have this, soft, warm blanket of federal liability preemption in place. But that's not the case, because if we take seriously people's rights to make their own health decisions, then we should respect the rights of patients and providers to come up with their own med-mal reforms, their own alternative rules that might involve the patient trading off some right to sue for a lower price. In fact, sort of the seminal case in this area, where judges knocked down those contracts between patients and providers, was one out of the University of California system. Bakke, I think was the name of it. And the judges said, we don't want those agreements between patient and provider. They just make us feel icky. Basically is what the judges said. But what happened in that case was a man came into the University of California system. I forget which hospital it was, and he was on a stretcher, and he signed away his right to sue in exchange for free medical care. And then there was negligence, and he died. But at the trial court level, the jury of his peers said no. He knew what he was doing, and it was a judge that overruled the people on the spot, the patient. And the jury, when the courts did that, what they did was they took away the right of every patient to make that decision for themselves, one that at least this one jury thought this patient was competent to make. And we would also see a lot of experimentation with different medical malpractice liability rules. So my point here is only that the community health centers should be subject to local med-mal rules, and but that doesn't mean the innovation would. You get innovation there as well. Innovation with ways to make those rules less burdensome, so you can still deliver on your mission.
So we're going to have another longer conversation around FTCA, because there was a time when FTCA was not in place for health centers, and it was a different time. And I think I hear what you're saying. It would be interesting to go deeper.
And it was a time when the courts were not allowing these sorts of agreements between patient and provider that I'm talking about. And I would argue that was the problem there,
right,
not liability itself.
Yes, I think, to connect the dots at the time, there was a reason why health centers needed FTCA, which is where we are now, and but it's a longer conversation that I'd love to have with you, because there's this I feel like there could be 10 different parts to our conversation if you'll come back and talk to me. But I have a couple more questions with you. I want to be conscious of time, because I could literally talk to you for another 2 hours. But I know that you are, first of all, so incredibly respected in DC for your expertise and your perspective on health policy. And that is talking from everyone from literal president of the United States to leadership in Congress to other think tanks to, literally everyone under the sun. So I'm curious, just, as we've been having the conversation and in the system that we exist in right now, because, there might be things that I know you would like to change, and certainly we would too, but in the system that we're existing in right now, what do you think is the path forward for health centers? And I think in particular with this administration and this Congress, what are the things, how should health centers be advocating for themselves, and where should we be going? What's your advice in terms of where we should be going?
Beef up your development teams so that they can appeal to the private sector for supplemental funding, because the federal money is not always going to be there. At some point, the music's going to stop. And I mean, you can say it already is, and I'd be interested to see data on what's happening at community health centers with Medicaid patients, or they're able-bodied adults who would have been Medicaid eligible, for whom you're getting nothing now from the federal government. I'd be very interested to see that. If that's happening, and I'm not sure it is, but it's plausible. If that's happening, it's only a taste of what is to come. So I've no problem whatsoever with private fundraising by federally qualified community health centers and people giving to them so that they can innovate in all of these sorts of ways. And it's not just the Medicaid money; it would also be your federal grants that I think you should be on the lookout for something to happen to them. And if you're getting Medicare GME funding, that's that is something that health economists are not the most powerful special interest group in Washington, D.C. But ever since Kenneth Arrow in 1963, they've said that those subsidies make no sense whatsoever. And so that's probably the second thing that they'll cut after Medicaid is that. So that is that's the bad news for if you want to keep the current funding model in place for federally qualified community health centers, is that that doesn't appear possible. So
would you say, if you were speaking to somebody in the private sector, based on some of the things you're hearing in terms of the innovations and what the intent, commitment, and frankly the model is, do you view health centers as a good investment?
Ooh, well, that's like asking me, Michael, what kind of health insurance should I buy? Where should I send my kid to school? What kind of stocks should I pick? No, I don't know. I don't know.
We'll go there.
Because it's very preference dependent, fact dependent. I don't know if I'm advising a foundation, if I would say yes to this or that or any community health centers. You gotta make that case to them, and I think that's why we're more likely to get accountability and innovation out of community health centers if they rely on private, to the extent they rely on private funding, because the private funders will be more demanding, I think, than the federal government will. Where if only because, I mean, if as with all federal subsidies, the people who receive the subsidies are able to capture the rules to a large extent and preserve their business models, and you'll probably get that's harder to do with private funding, and you'll probably have to innovate even more, I think, to the benefit of your clients.
Well, the good news is they're already held to an exceptionally high rate of accountability, whether it be from the government or the variety of funders that they have already, built relationships with, many of which, like I said, it's a beautiful and, intense patchwork of funding that is coming into any health center across the board. But I hear what you're saying, and I appreciate the candor in terms of, look, we need to be thoughtful about this. And in as much as, hopefully maybe you've learned some things about health centers in this conversation that stand out or give, pause for thought. They are a really vital part of their community. It's, I know you mentioned rural hospitals and sort of closure, and they're a large employer, and, people don't like when you say that. It's not dissimilar for health centers in terms of the role that they play in their communities, as sometimes the largest.
I know people who've used them, who've relied on them.
Many do. I mean,
right?
I myself, honestly, growing up in Maine, I spent a lot of time in the mountains in Maine, and the health center where I grew up, about half of my time, I didn't know it was a health center. It was just the family doctor.
Right.
But there were no other providers for probably an hour, and that's where everybody went. But to your point, a lot of, 34 million patients at this point, and I think that's the, at another time, because I really would love to have you back and talk more, but there's 34 million people who are relying on health centers for access to care. So the other bigger concern, or one of the big concerns, is if health centers start to falter and are suffering the consequences of, whatever the case, whether it's Medicaid or grants depleting or whatever the case may be, you're talking about tens of millions of people who suddenly don't have access to care and who either end up in emergency or prolong access period. And so that looks like more costly care. It looks like unmanaged health and, greater costs across the board. And so that'll be for everybody, regardless of how it works out.
Not necessarily for everybody, because one of the challenges that community health centers face, and I'm not saying that what you're saying is wrong, but it may not be for everybody. They face the Samaritan's dilemma, which is the idea that if you want to help the poor, you don't want people to suffer. That's good. We can help people, but to the extent we help people, we discourage them from helping themselves, and there's no way around that. The only way to make sure people are doing absolutely everything they can to help themselves is to provide them no assistance whatsoever. Provide nobody any assistance whatsoever. We don't want to do that. So when federal health centers, federal funding disappears, that doesn't mean that everybody who's using federal health centers is going to go without medical care. It's not going to be all 34 million. Is all I'm saying. It could be 30, it could be 20, it could be 17. I don't know. One of the challenges of the Samaritan's dilemma is that it is unknowable. But another dimension of it is because the federal government is pouring money into federally qualified community health centers, we don't know what would emerge in their absence.
I'm not sure I'd say they're pouring money into health centers. We're gonna back down on that one a little bit.
I've never met a lobbyist in Washington D.C. who said, "Whoa, God, you are pouring money into my
Agreed.
hospital program, whatever." No one ever complains that the prices are too high. The only complaint I ever hear is that the subsidies are too low. It's weird, the asymmetry.
I know, but I think I will pause on, there's money not pouring in.
And certainly compared to hospitals and the rest of the health sector, yes. You're not getting the subsidies.
Well, and again, I don't mean to keep adding questions, that I don't know if Cato has a relationship with Paragon, but it's been really fascinating to talk with some of the folks at Paragon about just their perspective on healthcare reform and sort of what the system is challenged with right now, its potential solutions, the role of health centers, all of it. There are some similarities that I'm finding in the conversation, and frankly, lots of differences. But yeah, I think all of the perspectives are so incredibly valuable right now. And, like I said, I would really love to continue the conversation to hear more about, you've given some suggestions around, okay, if federal funding entirely all the way around went away, that's kind of the scenario you're encouraging everybody to be planning for. And I know you won't give investment advice, but I think it would be really interesting to hear, okay, if you were to, again, if you had the magic wand and you were to redesign the system, including sort of taking away the federal dollars that exists for health centers, but understanding the model and maybe the values of the model and expanding on it. What would it look like? Like that's if we have another conversation or a part 2, and you may have an answer to that right now, but I'd love to get there, just because I don't know what happens in the next 2 years, but if we're moving in that direction, that's what we have to be thinking about.
Let's leave the audience wanting more.
Okay,
All right.
That sounds good. Well, I really appreciate it, Michael. It's been a fantastic conversation. I've learned a ton, and I just really appreciate your perspective. It's
great to be
super,
here.
super
Thanks.
valuable. Thank you. Michael, thank you so much for joining us and bringing a fresh perspective on this conversation. Community health centers play an essential role in caring for underserved communities, but as we've discussed, their future will depend on how well policy, funding, and incentives align to support that mission. This is a moment of real change in healthcare, and conversations like this are critical to understanding what's working, what's not, and what comes next. Thanks to everyone for listening to Community Health Centers Unfiltered. If you found this discussion valuable, be sure to subscribe and share it with a colleague. We'll see you next time, and thanks for all that you do.